All right, let's continue with TBI. TBI stands for traumatic brain injury. TBI is an acquired brain injury, so not something that you are born with, which is caused by either a stroke, like we talked about previously, a tumor can cause it, a blow to the head, so like a car crash or a punch or falling, a penetrating injury, so like shrapnel or possibly a bullet, or also parasites. That one's pretty gross, but it always sticks out to me. I think because one time I saw on the news that somebody ate undercooked pork and then they had weird neurological symptoms, and it was caused by a parasite, a brainworm, basically, from the undercooked pork. So don't eat undercooked pork, and that's going to knock out a very low percentage of acquired brain injuries. That's so much more risk of all these other ones. But anyway, stroke, tumor, a blow to the head, penetrating injury, and also parasites. These are going to lead to impairments in a bunch of different areas. Not everybody is going to have all of these areas of impairment. Some people will have all of them, and some people have some from the list. So speech and language, which two different things, right? So speech is the motor process. Language is the ability to find the words. And a lot of these language issues we're going to talk about in more detail in a little bit. We'll talk about all sorts of types of aphasia. But the speech would be a totally different thing. That is just the motor process. Cognition, so just like general cognition, decision making, task switching, multitasking, stuff like that. Motor behavior, so walking, moving your arms, and then also psychosocial behavior, which is just like how you interact with others. It's the pragmatics aspect, if you think back to when we were talking about ASD. So let's talk about prevalence of TBI. There's 2.8 million TBI visits per year. And this is not including stroke. So they're considering these totally different things. Stroke is one thing, TBI is another. The what can end up happening based on a stroke or a TBI is often the same. It's all damage to the brain. But they, since the risk factors are a little bit different, you see prevalence listed separately for stroke and TBI. So TBI is 2.8 million visits per year. A lot of these are from car crashes. The vast majority of these are from car crashes. 224,000 people are hospitalized every year for TBI. Another large one is from falls. So car crashes is a huge one. People visit for TBI. 224,000 are hospitalized. Most of those are from falls, like in the house. Elderly people getting in and out of the bathtub, or just anyone doing some sort of work where they might fall. There's 61,000 deaths per year. This is all within the U.S., by the way. And a lot of those are firearm-related suicide. That's also TBI. And males tend to be at greater risk of TBI, non-stroke related TBI, than women. And can you think of reasons why that might be? If you said because men do stupid things, you're right. Men are more likely to do stupid and risky things. There's just more risk-taking behavior for males. Hooray. Is it innate? Is it learned socially? Is it both? It's probably both. But whatever the fact is, it is true. Men do tend to do more dumb and risky things that can result in physical injury. Some of them are just like the jobs that men tend to have. So like construction jobs, you can have falls and stuff that are related to that. But then there's also a lot of like, I'm going to jump my ATV over my friend's car, and that's nobody's doing that for a job. Well, a few people do that for a job, but not many. Most of the people who do it are not doing it for a job. Okay, so that's TBI prevalence. Within TBI, there are two different types of traumatic brain injury. There's a closed head injury and an open head injury. The closed head injury is the one that can happen, like at the top here, concussions in the NFL. There's another male-dominated thing that can cause TBI. So closed head injury is a car crash. So you get the head hit. Sport, where you take a lot of repeated blows to the head. Anything like that, a fall. That's a closed head injury. An open head injury is where the skull is opened, and there's like a pathway through the skin and the skull into the brain. So the brain is essentially exposed. That's an open head injury. Both can cause TBI. Open head injury, you're going to see a lot of times in shootings, or on the battlefield, which would also be bullets, but also shrapnel in those cases, or, mostly just shrapnel and bullets. And then the next picture down, car crash, you've got usually closed head injuries there. And then you've got this guy. This is a penetrating head injury. This guy, if you had, you probably learned about him in Psychology 101 if you took a Psychology 101 class. This is Phineas Gage. What a crazy name, first of all. He had a penetrating head injury. A penetrating wound, like I say here, the skull is opened. Bullets, shrapnel or debris, or in Phineas Gage's case, a railroad spike. So essentially, I've looked into this case, and there's one thing I don't understand about all this stuff with Phineas Gage, which is, so he's working on a railroad, putting together, railroad, and somehow they're driving in rail spikes, and somehow TNT is involved. And this is where I don't understand. Maybe it's because I don't build railroads in the 1800s, but I don't understand why there's TNT involved with rail spikes. It just seems dangerous. I'm surprised that there weren't more people that had rail spikes going through their head. And maybe there were, they just didn't survive. So anyway, Phineas Gage goes to pound down this rail spike, and somehow it detonates the TNT or whatever. So it blows up, and it shoots the rail spike. You can see on the image right down below, up, right here on the side of the jaw and the maxilla here. It goes up under the zygomatic arch, behind the orbital socket, behind the eye, and then up through the brain, like that. Phineas Gage, shoots through the head. It goes out, all the way out the top of his head, and he falls over. There are writings from a doctor that was on site at the time, and it's the 1800s, so doctor is a term that's used loosely. And so he runs over and he looks at Phineas Gage, and the writings say I was pretty sure he was dead because he wasn't moving. So what I did was I put my fingers in his head and I could feel his brain. And I am not joking, that is exactly what's in this guy's writings. He's so I was touching his brain, and then he woke up. And then we took him to probably not a hospital. They took him somewhere, and to the closest place where he could get medical attention. And he lived. And for having that much of your brain blown away by a rail spike, he didn't have too many deficits afterwards. Intelligence seemed intact. Most of personality seemed intact, although he didn't have a filter anymore. So some people at the time when they were talking about him, they said that he was a really nice guy, and then he ended up not being a really nice guy. But when you look at the kind of things that were happening when he was not being a nice guy, it wasn't that he was going out of his way to be mean. It was that he was just saying all the things that popped into his head, and not all of them were nice. And so that seems to be the main deficit that he had, was a filter, like knowing to not say all the things that you're thinking. That would be that psychosocial pragmatics issue for his TBI. I think there was also some slurring of speech and some word finding errors that he had, but those tended to come on as he got tired or a little drunk or something like that. So they weren't too bad, this is just nuts that much of the brain can be gone and you're basically fine. Pragmatics are important. Okay, so let's talk about some closed head injuries now. So the closed head injury is the most common type. The skull might fracture, but even if the skull fractures, it's not considered a penetrating injury. So you may have a fracture in the skull. You may have a little bit of bleeding, but there's not a large gaping wound into the brain, so it's not considered an open head injury. But there is something called a coup-countercoup injury, and that's what's in the picture that's underneath my face. Hang on. Okay, so this picture up here, what's going on here is a coup-countercoup injury. Think about this as you're in a car, you're driving, you rear end somebody. So what's going to happen is your head goes forward. Oh, coup-countercoup, French for blow and counter blow, opposite blow. So you're driving a car, you rear end somebody. The first thing that happens is your head moves forward, and it can either impact something, or you can get a slight coup from not impacting anything. But I mean, what we're looking at here is hitting a fixed object. So you go forward and you might hit the steering wheel or the dash or something like that, especially if you didn't have your seatbelt on. And that's going to injure the front of your head. It could crack the skull. And then the brain inside, so you've got the cerebral spinal fluid that's kind of around the brain and cushioning it. But when the head moves forward and then the head stops all of a sudden because it hits something, it makes contact with something, the brain inside keeps moving. Even though there's cerebral spinal fluid in there, it runs into your own skull. So the damage here to the brain is essentially the brain hitting its own protective enclosure. So the head is moving, it stops suddenly, the brain runs into the front of the skull. Then the head and the brain are going to rebound back, and then the brain is going to make contact with the skull on the other side, and that's the countercoup. So you've got coup-countercoup injury. So you've got injury where you make contact, and then injury on the opposite side of that. It could be side to side if it's a concussion, so you could have like coup-countercoup, but the forward back is tends to be more common. Whatever the case is, you're going to have a blow, and then on the opposite side, you'll have the opposite blow. So coup-countercoup. Oh, okay. So let's see. I need to click here and move forward this. Yes, and then I need to move my head. This is a brain that has had a coup-countercoup injury. Obviously, the person died because we have their brain. So you can see that it was coup-countercoup here. This is the coup. There's a lot of bleeding there, and then it came back and it hit here. This blood has come around on the sides as well, so there was quite a bit of damage from that first frontal blow. Damage all the way around into the temporal regions. So, not great. I will let you read this. This is just the TBI severity classification system. This isn't on the exam, but if you're interested in this, come back to this slide and take a look at it. But I do want to talk about this. Mild TBI, which is a concussion. So any concussion that you have is an injury. It's not an injury that's going to necessarily give you all the hallmarks of a traumatic brain injury, because it's just one concussion, one small concussion. You're not going to get you're very unlikely to get massive TBI from just one concussion. But that's just one concussion. So a concussion is caused by a blow to the head. You could have this coup-countercoup, and you could get your concussion that way. It results in physical damage to the actual axons and dendrites. So what happens is, with the coup-countercoup, or whatever type of blow you get, most blows are going to result in coup-countercoup. But what happens is, as the brain contorts, it hits against the skull over here, and it'll kind of squish in. And then it'll move back, and that side will squish in. And what you get are these shearing forces that break apart the actual neurons that are inside the brain. They also cause bleeding in the brain too. Concussion may or may not result in loss of consciousness. Of course, if you do lose consciousness, that's a much worse level of concussion than if you don't. But symptoms from a concussion usually go away pretty quickly. If it's really light, a couple days, weeks, and if it's really bad, months. But if you get a lot of concussions, the effects are a lot worse. So what you're looking at here in this picture is a healthy brain on the left, and then you have a TBI over here. This is a concussion. This is repeated concussions. You can see all the areas. It's got the coup area over on the left side of the brain, on the second one in. You've got this large area where it's bleeding, and inside the brain there's also blood because of the shearing forces. You can see where it's pink. Those are other areas where the brain has had damage. It's kind of resolving in the next one. Some of the bleeding has stopped, but also some regions of the brain have been permanently damaged and essentially died. They are not getting blood flow, so these little regions have died off. And over here on the far side, this is CTE, which stands for chronic traumatic encephalopathy. And what's going on here, this is a disorder. It's not really a disease, it's a syndrome, where the brain, from repeated concussions, has essentially been damaged to the point where it seems like the person has dementia, but it can happen at a much earlier age than you typically see dementia. It can happen later as well, but it can happen a lot. You typically see it a lot earlier because the concussions start happening a lot earlier. If we're talking about football players, this is in their 20s that they're having all these concussions, or even earlier than that. Teens in high school, and then teens to 20s in college, and then 20s when they go play professionally. And so around 40, late 30s, early 40s, mid 40s, you can start seeing the effects of CTE, which look like dementia. It's not dementia, but I'm going to talk about that in just a second. So CTE, what I've got here is that it's a progressive disease, progressive degenerative disease, found in people with repeated head injuries. It's progressive. Every concussion allows it to progress some. It's also progressive once you stop having the concussions, because parts of the brain that have been starved for blood, that are dying off because they're not getting enough blood, continue to die. And so it's progressive in all senses of that word. A lot of the symptoms that you can get are memory loss, confusion, aggression is a big one, and also suicidal thoughts. If you look into some of the news stories of NFL players who have CTE. You'll see aggression. They get really upset and start, they could be really nice people. All of a sudden they become like domestic abusers. And what they find out is they die not very long afterwards. And then they look at their brain, they've got CTE. A different player, I can't think of the name, but had severe depression, ended up shooting himself, and then they did an autopsy. I think his wife had to lobby the courts for a long time to do an autopsy, and when they did it, they found out that he had CTE. So both of those huge personality changes were a result of all of these sustained concussions. Interestingly, the diagnosis can only be confirmed on autopsy as of right now. The diagnosis can only be confirmed from autopsy. Scientists are trying to figure out ways they can measure what's going on before an autopsy. So they can see if someone is in danger of having CTE with imaging instead of just waiting and seeing what happens. Or say there's a court case where they've assaulted somebody or they've killed somebody and maybe they have CTE. So should they be completely as at fault as someone who doesn't have CTE? Well, we don't know if they have CTE, if we can blame this on it until they have an autopsy right now. And that's why it's important to have this imaging data. This is some of the early studies that are looking into showing us imaging data. This is areas where we see volume reduction. The control is on the right. You see that there's not really any volume loss in any area of the brain, just some changes, random changes. CTE is in the middle, and you can see that the areas of the brain that are most affected are right in the middle, so like the brainstem, the thalamus, areas like that, and then also towards the middle, maybe that's like roughly like an insula area, but you can see all the areas where it's red. That's what's most affected. And on the right is Alzheimer's disease, because CTE looks like dementia or Alzheimer's before you can confirm it with an autopsy. They act the same way. So the presenting symptoms are, I'm confused, I'm forgetting things. People with Alzheimer's disease can start to get aggressive as well. They can also become depressed. So it really looks like dementia, but it's not. And you can see that the volume loss has a completely different pattern. Alzheimer's disease is kind of everywhere. It's globally, and it's all about the same level. It's all that green color. CTE, you can see that it's not happening in all the same areas. There's other areas that are more preferentially affected. Those are the red areas. So if we can continue doing this research and find out more about what the progression of CTE actually looks like, we don't have to rely on the behavioral symptoms. We can then start looking at the imaging and show that somebody likely has CTE. The reason that you can tell during an autopsy is you'll actually see the brain look like more like this. You can tell that there's been repeated injuries. In a person who has Alzheimer's, you don't see this. You don't see all this bleeding in areas of the brain that have atrophied because they didn't get oxygenated blood. Okay, let's continue. So what deficits could you expect from TBI? We kind of talked about this already, but attention deficits, memory deficits, deficits in orientation, like figuring out where you are, what time it is, things like that. Executive functioning, so decision making and memory, and then also reasoning and problem solving. That's kind of self-explanatory. In the speech and language area, we've got auditory comprehension, so we haven't really talked about that, but you can have issues just understanding what you're hearing. Anomia, so not being able to find words. Reading and writing deficits. Motor speech disorders, which we talked about, just the motor part of speech. And then also pragmatics like Phineas Gage. This is a video that I have for you to watch. It's like directly under the link for this video, so it should go part 1, then part 2, And then under this are this video and a video that we'll see in just a second. This woman had a TBI, and she's talking about the difficulties that she has in her life. One of the things that I want you to pay attention to when you watch this is she says that she can be doing something, somebody will talk to her, and it'll take a while for her to reorient herself to pay attention to what the person has said. And then even once she's listening to what the person has said, it could take up to 15 minutes, 15 to 20 minutes, I think, she said, to figure out, to finish reorienting herself to answer the question correctly or respond in the correct way. Which is crazy, right? Because most of us can do it immediately, basically. So watch that video. And then this is kind of a complexity timeline. It's not time, but it's like a complexity line of attention. So we start with just responding to stimuli. So you hear a noise and you look. That's just the easiest kind of attention you can have. It's really easy. In fact, it's so easy that it's automatic in most people. The jump scare, which would be really great if I went back in and edited this video to have like a scary old man jump out. Anyway, I probably won't do that, but maybe it already happened. Maybe I did go back in and do it. I don't know where I'm going to put it. Who knows? Anyway, it's easy. It's quick. The reason why jump scares happen is because you get a quick flash of like light. Your eyes just see a change. You don't even get time to process what it is. And then you also hear something that's like loud and shrill. And both of those just trigger an orienting reflex, which is a jump. And there's your jump scare. It's a real cheap thing. Horror movies shouldn't rely on this. They should scare us in other ways. Whatever. So that's the easiest kind of attention. Then you've got sustained attention, where you're looking directly at something like this video that you're watching. So you're using sustained attention now. Then you've got selective attention. You want to focus on one stimuli and ignore the others. If you have kids, you're doing selective attention, unless they're somewhere else. Alternating attention is shifting attention between the two tasks. I think we all know about this, right? Texting and driving. No, don't do that. But that is what you're doing. You're shifting your attention between the two. Don't do it, but that's what you're doing. And then divided attention is responding to multiple stimuli at the same time. That's actually probably what you're doing when you're driving. It would be the better way. Just don't text while you drive. But I know that a lot of you do, so it's a good example. Okay, let's talk about memory really quickly. You've probably heard of long-term and short-term memory, and you may have heard about working memory before this class, but definitely you've heard me talk about it, just kind of allude to working memory before now. Well, long-term memory is something like knowing your address, what high school did you go to or graduate from. This is just stuff that's in your brain long-term. You can pull it up from way long ago and like know these facts. What are the names of people in your family? What city did you go to on vacation after you were 10 or something? I don't know. Whatever. After you were 10? What a crazy thing to say. So that's old stuff. Then you've got your short-term memory. Who visited you today? What did you have for lunch? What was the name of the guy with the rail spike through his head? Short-term memory, right? So this is stuff that's just happening right now. You may not move all that stuff to long-term memory, or maybe you do. You're probably not going to move what you had for lunch today to long-term memory. Probably. I would be surprised if you did. Then you've got working memory, which is very different. So working memory is holding information in the focus of attention in your mind while you're mentally working on it, or keeping it in the focus of attention while working on a different problem. So they're slightly different, but they kind of do the same thing. You hold information and you're like doing things to it, or you hold information and you do something else and then come back to that information. It's both working memory, and people that are good with one are usually good with the other. Let's test your working memory right now. You could do this on paper. You could do it just thinking, whatever. If you want to do it on paper, pause the video right now. Go get something to write on. Write it on the notes in your phone or whatever. Whatever. Okay, so pause if you need to, and we're going to start. So what I want you to do is remember the following numbers. I'm going to read to you and show you some numbers, and then I want you to write them down in the opposite direction. So if the numbers were 1, 2, 3, your answer would be 3, 2, 1. Okay? Here we go. 7, 9, 4. Opposite direction. What did you get? Should be 497. Because it was 794, you're going to reverse it. So you should have 497. Okay, let's do another one. Probably most of you got that. Good job. And now let's do this one. 3, 6, 2, 9, 4, 0. So take all those numbers that you've remembered, reverse them, and then write them down. Don't cheat by writing the things down as I'm reading them to you and then just reversing them. That's not how you do it. Remember them all, reverse it, write down what you reversed. Okay. You should have 049263. Okay. We talked about how people with TBI can have trouble orienting themselves. This could be orientation to like who is coming to see them, where they are, the time it is in the day, and even like what they're doing. So sometimes they'll just be doing something and it's gone. Oh, what am I doing here? And it's not like when we walk into another room and then forget why we went there, which happens, and it can happen to people with TBI too. This is more like they are currently doing the dishes and then they kind of forget why they're holding a plate. Okay. This is similar to what we talked about with ASD, executive functions. They're controlled in the frontal cortex. They're high-level cognitive processes that get us to like goal-directed behaviors. So you change what you're doing, decision-making, inhibition of irrelevant behaviors, so like pragmatics and stuff like that, planning and decision-making, maintaining and updating your goals, which you could also consider that. Decision-making, these are all executive functions. And if you have TBI, especially focused here on the frontal region, these are things you're going to have trouble with. So some common language deficits after TBI are recalling word names, difficulty organizing words and sentences. You're going to produce shorter and less complex sentences. These are like memory, planning, and organization. For those other two, you will have problems making inferential judgments. And this one's really interesting to me. But your ability to understand metaphors and sarcasm can just evaporate with TBI. Sarcasm, all of a sudden, you can't detect when something is sarcastic, and you can't detect when someone is speaking metaphorically. So that's kind of like cognitive reasoning is inhibited. This is another video that I've got a link right below this one, so go ahead and watch that. This is about a few different people who have TBI and how it is affecting their lives. You'll see all of the things that we talked about come in. This guy right here, he's got the problems planning what he's going to say. He's got problems with, well, you'll see that the goals that he has for himself are play the guitar again, use the toilet by himself. You'll see when he talks, he doesn't move his hands exactly right, so he's got motor issues. The sentences are very short and simple. There's a lot of things. His was a car crash, not wearing seatbelt, so he got that, front of the head injury, the coup-contrecoup, classic coup-contrecoup thing going on, and TBI from that. There's a few different ones. If you want to watch the whole video, you're absolutely free to watch the whole video, but if you just want to watch the first 5 minutes, you'll get some good information from the first 5 minutes. So if it's not really hitting for you, you don't have to watch the whole thing. And if you're really interested in this, go ahead. Okay, next we're going to talk about aphasia, but that's right here. This is where I'm going to end the second part. So I'll be right back with aphasia.